We are going to start our introduction to modalities with the idea of inflammation and tissue repair. So this is going back to what we talked about in pathophysiology last quarter. But in this class, we're going to look at it through the lens of how do we affect inflammation and tissue repair with physical agents, with modalities. So the foundation of a successful rehabilitation program requires an understanding of biomechanics, which we learned about in kinesiology, phases of tissue healing, the effects of immobilization, and therapeutic interventions on the healing process. So a lot of times I talk with people, patients when I'm working with them or other people, and I always say physical therapy is not drastic. Physical therapy is conservative treatment. What I like to say that we do in PT is we nudge people in the right direction. We make sure that people are doing the things that they need to do to affect their inflammation and their tissue repair. The things they can do, so there are some things that we can do with tissue mobilization and modalities that can accelerate the healing process, can push things in the right direction. We're not doing surgery. We're not doing anything drastic. We are nudging people in the right direction. So in order to do that, we know about tissue repair, and we're going to learn about these agents that affect tissue repair, and how can we sort of usher people down the correct path, if you want to think of it that way. So as rehabilitation professionals, we treat inflammatory conditions resulting from trauma, surgical procedures, sometimes problematic healing. The treatments we use are physical agents, or physical therapist assistants, therapeutic exercises, and manual techniques. So that's our bag of tricks. And so in this course, we're going to be talking about physical agents and starting into manual techniques. Of course, next year you're going to have a manual therapy class where we're going to talk about even more specific manual techniques, and hopefully by then you'll have a really good base to build on and start expanding your vocabulary of manual techniques. So this is a picture from the book talking about the phases of inflammation and healing. So the first phase, the inflammation phase, days 1 through 6, basically prepares the wound for healing. It's a protective response. It's an attempt to destroy, dilute, or isolate the cells or tissue at fault. So we talked about this in pathology. Our body has a response to anything that happens, any kind of assault or change or some departure from homeostasis for whatever reason. And it is attempting to destroy a foreign invader, to dilute maybe chemical imbalances, or to isolate the cells or tissue at fault. So it's necessary for healing. We have to get this going. We get in the inflammation phase, we get constriction of the arterioles to prevent excess blood loss and excess exposure to bacteria. So we're trying to maintain hemostasis. We're trying to if it is bacteria involved, we don't want to let them get around. So we're going to restrict. We're going to have that vasoconstriction. That is followed by vasodilation of nearby uninjured vessels and increased capillary permeability. So that increased capillary permeability shows up as the cardinal sign of swelling, redness, and heat. So our cardinal signs of inflammation, redness, heat, swelling, pain, and sometimes loss of function, because we're trying to isolate the cells or tissue at fault. So we get that capillary permeability, it causing the swelling, redness, and heat. Pain often results from increased swelling because there's increased pressure on the tissues. We get neurochemicals released from damaged cells, and sometimes those chemicals have an effect on pain, and we'll talk a lot more about that. the pain and swelling might result in loss of function. So that's all in the inflammation phase. We also start to get clot formation if there is a wound. Phagocytosis follows. The macrophages come in response to the chemical signals sent out by the cells, and the macrophages stay until the inflammation is gone. So they're there to clean things up. They need to clean up the mess. That's their job. So if there aren't enough macrophages, then you have decreased fibroblast activity, and the fibroblasts are the ones that send out the histamines. So that inflammation phase is really important for preparing the wound for healing. So the proliferation phase rebuilds the damaged structures and strengthens the wounds, and that's generally day 3 to 20. And these phases, of course, overlap, and people don't walk in the clinic with a sign around their neck that says, I'm in the inflammation phase, so we know how to treat them. But we know the signs to look for, and so we will know what phase they're in. A lot of times when we get people in physical therapy, they are often in the proliferation phase or sometimes in the maturation phase. And we're talking about wound healing here. So in a proliferation phase, days 3 to 20, the body's working on rebuilding and strengthening the wound via replacement of that damaged epidermis, which is called epithelialization, re-strengthening connective tissue, so there's a lot of collagen production going on. Fibroplasia is what they call it. Those fibroblasts are shooting out that collagen to fill the wound. I always say that collagen is the spackle of our bodies, so we're filling holes now. And then we get wound contraction from myofibroblasts, are the cells that are doing that. So the wound starts out large and it starts to shrink, right? And we get new vascular supply occurring. We get neovascularization, developing new blood supply for those new tissues. So at that time, because we have that new vascularization, the scar is red and swollen. We have increased vascularity and increased fluid. So even though the patient doesn't have a sign around their neck that says, I'm in the proliferation phase, we have a wound that's nicely closed up because of that epithelialization and the collagen production. The wound has contracted a little bit, so it might be a little bit bunched up maybe. And it's red. We have that neovascularization. So that's as good as a sign around their neck, right? It's a sign right on their injury. The tensile strength of the scar is still low. It's as low as 15% of normal tissue strength. So there's a high potential for re-injury. So during this proliferation phase, it's a high protection phase. We need to make sure that the scar tissue is lying down in a functional way, but we're not putting a lot of stress on it at this point. The maturation phase modifies the scar tissue into its mature form, and it is from day 9 onward. Of course, these phases vary in duration for different people with different bodies. I always say our bodies are not machines, but in the maturation phase, we also like to call it the return to function phase, because that's where we can really make a lot of differences in physical therapy. How we get them to move, how we treat their tissues is going to help them have really good functional scar tissue in its mature form. Collagen synthesis is balanced with collagen lysis, so we don't get too much scarring. The collagen fiber orientation is changing in results to forces that we put on it, and we end up with a nice healed injury. So for functional scar formation, we need a balance between new collagen formation and old collagen breakdown. When the scar is rosy pink, it is remodeling. It's working. So we can do things like scar tissue mobilization and the exercise that we do with people, and some of the modalities that we apply can help form a really good scar. So the scar heals in the patterns determined by the stresses to the remodeling area. So if we keep stretching it, we work on range of motion, we're going to have a nice functional scar. And that's what we want. So this is from the book as well, and it kind of shows how the stages might overlap and how they kind of days from the time of injury, how it goes out there. So in that inflammation phase, it's the first few days, there's a lot going on. The proliferation phase, it's sort of our protection phase, where the wound is healing, but it's not, the tensile strength is really low. During the maturation or the return to function phase, that's when we can really do some good functional stresses to the remodeling area and affect how that tissue lays down. So in the inflammation phase, and this is just a review of what we talked about. Sometimes you can get inappropriate inflammation where the inflammation's out of control. If you have an autoimmune disease, it's often has inflammatory properties. It can cause damage and extensive scarring, but the inflammation phase is necessary for healing. So part of what we're doing during the inflammation phase is we're trying to teach people about the right way to manage their swelling and manage their pain and manage their wound without causing damage and increasing the amount of scarring. So we have our vascular response, inflammation. It's the Latin meaning to set on fire, associated with heat, redness, swelling, pain, and loss of function. The vascular response is mediated by those cellular chemicals, the histamines, the kinins, and the prostaglandins. They cause swelling, redness, and also pain. Immune response, activating the neutrophils and other infection-fighting cells, and the complement system that we talked about a little bit in the immune chapter in pathophysiology. And then our hemostatic response to stop the bleeding. We really want to make sure we're stopping the bleeding. So here's our little vascular response. Those macrophages are oozing out through the capillaries because we have more permeability, and they're going out there to save the day. Macrophages save the day. So here they are. They go, oh boy, chemical signals. Let's go out and get them. They go out and they find their target cells or target organisms or target material that they are then going to eat and take out of the way. So these are pictures from the book on page 29 in chapter 3, and they talk about how the capillary beds open and the vascular changes associated with acute inflammation. Of course, most of these vascular changes show us the signs that we see, the cardinal signs. So lots of cells and fibers involved in the inflammatory response. Intravascular cells, connective tissue cells, and cells involved in the inflammatory response. And we'll talk about in the next couple lectures the connective tissue cells and the types of tissues that they create. So here's our little macrophage. It says, oh look, there's some debris from the wound. I'm just going to get rid of it. Take it out of here. So in the proliferation phase, the wound is strengthening. It's the epithelialization, forming new cells, collagen production, and it produces what's called granulation tissue. That's that rosy tissue. We'll talk about the types of collagen in one of the next few lectures. And initially, we're doing type 3 collagen. The wound contracts, and we get that neovascularization, the formation of the new blood vessels. So here's our nice surgical wound. It's nice and clean, and we talked about healing by first intention in pathophysiology. And cells, the epithelial cells, start to migrate to the area. They start to contract the wound and hold it in, and that's our epithelialization step. So the collagen is formed by these individual tropocollagen molecules that join together to ultimately form the collagen fibers that are the spackle of our body that form the scar tissue. So like a lot of the molecules in our body, like muscle fibers and I mean, collagen's the same way. It has tiny little units that bundle together into bigger bundles and bigger bundles and bigger bundles until you get the tissue that you want. So there's a thing they talk about in the book that's called the picture frame theory of wound contraction, meaning the wound doesn't just get shorter or less wide. It sort of contracts all as one wound, as though you were shrinking a picture frame. Hopefully that makes sense. So this is just a review of the healing by primary intention and secondary intention, or healing by first intention or second intention. The clean surgical wound versus the larger, less organized wound. And just a review of what we talked about last quarter. So the maturation phase, or the return to function phase, can persist for more than a year after the injury. So that balanced synthesis and lysis of collagen are required for the normal remodeling of the scar. So if production of new collagen is greater than the lysis of the collagen, then you get keloid or hypertrophic scars, which they're bigger, thicker, they're less mobile. Sometimes people have to get part of the scar removed, which of course then causes more scar tissue. Sometimes if you're in a condition of high oxygen exposure, it favors collagen production over lysis, and so it favors hypertrophy of scars over smaller scars. As the scar matures, the type 3 collagen, which is the weaker type, is replaced by type 1 stronger collagen. So the scar itself is maturing for a very long time. And so a lot of times, like I see a lot of people with total knee replacements, just because we have a total knee replacement program at the clinic where I go. And when I talk to, I often run into them out in the community. And a lot of them say to me things like, they say, well, 6 months after the surgery, I felt pretty good. A year later, I almost forgot I even had the surgery. So it really took that long for them to get back to normal, or back to what they felt to be normal. So even though the initial phases of healing don't go on very long, that return to function or maturation phase lasts a pretty long time. And a lot of times we're doing education with people to make sure they know that. They're not going to be as good as new in 6 weeks. It's going to take a while for them to get back to normal and have that scar be as strong as it can be. So there are lots of different factors that can affect the healing process. So there can be local factors, certainly, external forces, and systemic factors. So we'll talk about those individual ones. So local factors include the type, size, and location of the injury. Obviously, a small, clean wound is going to heal faster than a larger, rough wound, if that makes sense. If you have a wound in a place that has a lot of motion, like your knee where it bends a lot, that's going to affect healing, certainly, because you're always bending it. You're always creating some disruption there. The vascular supply is going to affect it. So what part of your body, the location of the injury, if it's in a place with less vascular supply, it's going to take longer to heal. Infection accounts for 50% of the complications of wound healing. So as we know, we have tons of normal flora in our system, and a wound is a fine opportunity for some of our normal flora to get places where they're not supposed to be. And those guys are opportunistic pathogens, and so they can cause infections for wound healing. So just this week, I had a patient that I was working with after her total hip replacement. Unfortunately, she's had a kind of a long road. She had a hip replacement last year, which she ended up dislocating. She ended up having to have a revision, and she was coming along in her therapy, and then she didn't come one day. And I'm like, well, that's interesting. I go to call her. I look in the computer system, and she's been admitted to the hospital for an infection. So this poor woman has had a long road. Her healing has been delayed by a lot of different factors, and now infection is one of those factors. She's getting IV antibiotics to treat that sepsis. So external factors can include therapeutic use of physical agents, cryotherapy, which is cold, thermotherapy, which is heat, therapeutic ultrasound. We'll talk about how that affects healing, electromagnetic radiation, UV light, laser light, electrical currents, and mechanical pressure. All of these can be used in attempts to modify the healing process. Early movement may delay healing. So we want to move in a protected way during that proliferation phase, but if you move too much, you can delay the healing by disrupting that the healing effect. So we can use physical agents to move people in the right direction, modifying the healing process. People can overdo it. It's possible to overdo it and move too soon and delay healing of a wound. So with systemic factors, of course, age is going to affect things. Healing is more rapid and robust in children than in the elderly. We all, unfortunately or fortunately, depending, are aging all the time. And so children are going to heal faster than the elderly. So a lot of times we don't see children in physical therapy a lot because even if they get an injury, like they break their arm or have surgery or something, they often don't need therapy to recover because their healing processes are right on it, and they are just in there healing. And a lot of times the children we do see in therapy are people either with more extensive injuries, like they were in a car accident or a fire or something like that, or children with developmental disabilities, and then therapy for them is a lifelong experience. So disease, of course, can affect healing. Diabetes is a terrible disease that affects all your systems, and it slows down your healing. Immune suppression or vascular system diseases can also impair healing. Medications that have systemic effects, well, how many of those are there? Lots of medications have systemic effects, and they can affect healing as well. And nutrition, fuel for inflammation and repair. When I was in school, I did one of my full-time clinical assignments at a Swedish hospital in Seattle, and they had a nice food plan for the patients. They didn't have set menus and set schedules. They had specific menus for people's specific conditions, and then that person could call up and order anything off their menu at any time, and it would be delivered to their room. So a lot of times we would go into somebody's room after an orthopedic surgery, and we'd say, have you had anything to eat today? And they go, oh, I don't really feel like eating. And we would call up the kitchen and say, hey, get me a protein shake up here for this person. Like, what do you want, vanilla, chocolate, or strawberry? And get them going on a protein shake because they need fuel for their inflammation and repair. So with outpatients, of course, you can talk to them about their nutrition. You can talk to them about making sure they fuel their recovery because that can be a really important systemic factor. Infection, of course, if it's a systemic infection like my one poor patient this week, that can delay healing, and so that's something to get on right away. Get the person referred back to their physician if you're involved in it, or following up with them, making sure they're getting the care they need to fight that infection. So we're going to start going into the idea of inflammation, of chronic versus acute inflammation. So acute inflammation is usually no more than 2 weeks, and anybody, probably every one of us, has sprained an ankle, dropped something on your foot, gotten a paper cut or something, and that's our acute. The acute stage, it doesn't last more than 2 weeks. You're hating it, but there you are. Subacute is usually more than 4 weeks, and chronic can last for months to years. So chronic inflammation can arise from the persistence of an injuring agent like cumulative trauma. Several years ago, I worked with a lady after a knee replacement, and she was doing really well, actually. And then she got in a car accident. So the impact of her new knee on the dashboard um, gave her a tibial plateau fracture right around the prosthesis. And so there she had some cumulative trauma, and it interfered with her normal healing process. And it was probably a good year and a half before she was back to walking. She had to be non-weight bearing for a good amount of time because that tibial plateau fracture. There was some concern about infection around the prosthesis, and then she had to go from a wheelchair to a walker. It took a while to get her walking with a cane, and we finally got her back to her normal process, but she had a lot of inflammation, she had a lot of swelling because she wasn't able to move, and so she kind of slid into that chronic stage. When you have chronic inflammation, you a lot of times have an increase in scarring and adhesions, which reduces the strength and functional mobility of the tissue. So we talked about scar tissue is not as strong as normal tissue. It doesn't have the same function as normal tissue. It's really just there to fill the holes. So you get scarring, you get adhesions, which is the scar tissue sticking to healthy tissues around it, and it reduces your functional mobility. So chronic inflammation is really kind of a combination of active inflammation, tissue destruction, and healing. And it's a vicious cycle that can really lead to inflammation lasting for months or years. And that's one of the things, by nudging people in the right direction, we want to get them out of the range of chronic inflammation.